This recording will go over monitoring for and managing heart failure, specifically managing left ventricular failure and hemodynamic monitoring. The most desired outcome for the patient is that he or she will be free from heart failure. However, if it occurs, the outcome is that the heart failure will be identified and treated early to prevent further complications. The most severe form of acute heart failure is cardiogenic shock. The type of management used to increase cardiac output depends on the location of acute coronary syndrome and the type of heart failure that has resulted from the infarction. When managing left ventricular failure, be sure to assess for manifestations such as crackles, wheezing, tachypnea, pink frothy sputum, and an S3 heart sound. Monitor for, report, and document signs of inadequate organ perfusion that may result from decreased cardiac output, including a change in orientation or mental status, urine output less than 0.5 to 1 ml per kilogram per hour, cool, clammy extremities with decreased or absent pulses, unusual fatigue, and recurrent chest pain. Hemodynamic monitoring is an invasive system used in critical care areas to provide quantitative information about vascular capacity, blood volume, pump effectiveness, and tissue perfusion. It directly measures pressures in the heart and great vessels. Hemodynamic monitoring is usually performed for more seriously ill patients and can provide more accurate measurements of blood pressure, heart function, and volume status. Hemodynamic monitoring does involve significant risks, although complications are uncommon. Therefore, informed consent is required. The physician inserts a balloon-tipped catheter percutaneously through a large vein, usually the internal jugular or subclavian, and directs it to the right atrium. When the catheter tip reaches the right atrium, the balloon is inflated. The catheter advances with the flow of blood through the tricuspid valve into the right ventricle, past the pulmonic valve, and into a branch of the pulmonary artery. The balloon is deflated after the catheter tip reaches the pulmonary artery. Waveforms are viewed on the monitor as the pulmonary artery catheter is advanced. A chest X-ray is used to check the location of the catheter. Right atrial pressure is measured by a pressure sensor on the catheter inside the right atrium. Normal right atrial pressures range from 1 to 8 millimeters of mercury. Increased right atrial pressures may indicate a right ventricular failure, whereas low right atrial pressures usually indicate hypovolemia. Normal pulmonary artery pressure ranges from 15 to 26 millimeters of mercury systolic over 5 to 15 millimeters of mercury diastolic and is constantly visible on the monitor. The tip of the catheter can sense pressures transmitted from the left atrium, which reflect left ventricular and diastolic pressure. The pressure measured during balloon inflation is called the pulmonary artery wedge pressure. So as they're threading the catheter through the heart, through the right atrium, the right ventricle, and up into the pulmonary artery, they can take a reading inside the pulmonary artery, and then they can also inflate a balloon and let the blood sort of pull the catheter along until it gets wedged into that pulmonary artery, and that's considered a pulmonary artery wedge pressure. The pulmonary artery wedge pressure closely reflects left atrial pressure and left ventricular and diastolic pressure. The pulmonary artery wedge pressure normally ranges between 4 and 12 millimeters of mercury. Elevated pulmonary artery wedge pressure measurements may indicate left ventricular failure, hypervolemia, mitral regurgitation, or intracardiac shunt. A decreased pulmonary artery wedge pressure is seen in hypovolemia or afterload reduction. Single values of these measurements are less significant than the trend of values combined with the patient's signs and symptoms. During pressure recording, it is important that the transducer be at the level of the phlebostatic axis. The patient is usually supine with the head of the bed elevated up to 45 degrees during hemodynamic readings, although the position may not affect results. If the balloon remains in the wedge position after the pulmonary artery wedge pressure measurement, try to change the catheter's position by asking the patient to cough or by changing his or her position. If these methods are not successful, notify the healthcare provider immediately. Inspect the insertion site for redness, induration, swelling, drainage, and intactness of the sutures. Be sure to assess for a number of complications associated with pulmonary artery catheters. For example, pulmonary infarction or pulmonary rupture may occur if the catheter remains in a wedge position. Air embolism is possible if the balloon has ruptured and repeated attempts are made to inflate it. Ventricular dysrhythmias may occur during insertion or if the catheter tip slips back into the right ventricle and irritates the myocardium. Thrombus and embolus formation may occur at the catheter site. Infection may result and bleeding may be pronounced if the infusion system becomes disconnected.